Hello, everybody. I am Haeok Jung from Catholic University of Korea. Interview of this RevUp meeting, RevUp interview KSC 2018. My co-interviewer, please introduce yourself.
I'm Dr. Jang Ho-bae from Gyeongyang University Hospital. Thank you very much for having this kind of chance to interview with Dr. Segupta.
Thank you very much for having me here.
Today here, we invite Dr. Pasu Sengupta, West Virginia University, USA. I have a great privilege and honor to be talking with you.
Thank you.
Dr. Sengupta is very famous for medical high-tech inventor as well as imaging cardiologist. So, first of all, Dr. Sengupta, please summarize your talk today.
Yes, the talk today was more towards the emerging role of mobile health technologies and the use of artificial intelligence along with all of these technologies. What's happening is we are seeing a growing burden of cardiovascular disease across the world. But there is also a shortage of healthcare professionals that is forecasted. So how do we bridge the gap between the need for the communities and our patients and whatever provisions are currently available for healthcare delivery? One of the ways to do it is to use new technology. And the new technologies that I discussed included mobile health and artificial intelligence. What mobile health does is it takes the ability to do all the diagnostics in the homes and in the communities. And what artificial intelligence does is to make the sense of the large amount of the data that comes from all these technologies. And there is already a lot of interest amongst the investigators worldwide in using AI not only to make sense of this data, but also be able to use it for predicting outcomes of interest. And these outcomes include important events like death and hospitalization. So if there is a way in a specific patient with his own data, you can predict a personalized way of knowing how this patient is going to behave over time. Then you can also develop methods to test in these particular individuals that could potentially work better than for the population-wide application. So it's more individualized and precise for a given individual. So that's the basis of the talk about mHealth and precision medicine and AI.
So you mean the tailored care by...
Tailored care.
Okay. But in other side, so many doctors or sonographers can be lost their job.
Yes,
what do you think about it?
No, I think there is a big question about how, when this new technology comes in, is it going to displace the physician and sonographers and technologists? So, in my opinion, that's not going to happen. For example, the automation that will come in is going to actually relieve the physicians and the sonographers, because currently they are like being pushed to do more work in a limited short period of time. And therefore the quality of the work goes down. Instead of that, if the low-hanging, mundane measurements are automatically done, then you can spend more time on communications, on making a quality report, making your interpretation in context of the clinical scenario. And some of these more complex activities which require general intelligence, common sense, is not currently available with AI.
Okay.
So what we will do is we will use AI for doing some routine low-hanging tasks, automation, fast, but then you will utilize people with their own experiences to make more sense and provide a personalized care. I also feel that a patient-doctor relationship is extremely critical because patients there's an intense emotional connection when someone has a disease. And currently, at least, machines don't have emotions. But doctors can connect to the patient, and the way we take care empathize with the patient is very important, because that gives them the reassurance that some therapy is going to work or not work, the trust. So the patient-doctor relationship, what this machine learning is going to do is to give you more time to do that.
Okay.
Currently you don't have the time. You're just trying to make sense of all the work, so it will free up your time. And that's what exactly I've mentioned in my recent editorial in Circulation. Actually, that comes in this week.
Dr. Bay, any question?
Yes, I enjoyed your talk today very much. And in Korea, recently, oncology is a very already commercially available using artificial intelligence in Korea. However, we have no experience with AI in Korea. But from your lecture, you showed the artificial intelligence use in valve replacement. So it gives us a better clinical outcome than those without the AI. So it is very, very interesting. So my question to you is there any field other than valve replacement surgery in cardiology, such as coronary artery intervention or decide to medication or intervention, especially in intermediate lesion or complex lesion?
Yes. So in general, I think what we see, particularly if you look into the literature where investigators are using AI very, very well, is to be able to risk stratify patients. So be it valvular heart disease, be it coronary artery disease, or any other disease. The patients, when they come with chronic cardiovascular disease, so be it coronary artery disease or valvular heart disease, they're not coming in isolation with that valve problem. They come with a lot of comorbidities. And when you have lots of comorbidities, traditionally, statistically, what we have done is we try to develop a multivariable model in research to adjust for all the associated abnormalities to see the success of the therapy. But the interesting aspect is all these models that are done statistically are linear models. The linear models actually do not work very well in real life. Real life is very complex. 1 + 1 is not 2.
Yeah, right.
Is 22, or it may be a very complex interaction. Machine learning is extremely good in understanding the complex interaction. And for those reasons, understanding the risk stratification becomes much more robust using the newer machine learning algorithms. There is another possibility, and which is important, is that it can take an enormous amount of information about an individual. So you are not limited to 10 or 15 features, for example. You may be able to take hundreds of features in a given individual. You may be able to take the zip code where they are coming from, the kind of risk factors that they are exposed to, put that all together and make a unique risk stratification scoring. So it is not just valvular heart disease. Machine learning, for those reasons, is also applicable for coronary artery disease. The complexity of the lesions and the associated comorbidities, should the patient may benefit more with CABG versus doing a PCI, should there be a SAVR or a TAVR? These questions are going to be addressed using new machine learning models. And it's very eminent.
Okay, one more question is, it is anyway very interesting and very pioneer in cardiology using AI, but I'd like to know the current real situation in your hospital or any other country. So do you use currently or real clinical world or?
Yes, so the answer is AI has already come and it is working in the background, and we don't even know. So most of the diagnostic systems, let's say echocardiographic systems, already have AI. So currently, for example, we make the measurements in EF and chamber quantification. I'm already using AI. So there are softwares which automate. We just put 3 points and it takes over and does all the calculations itself. So the answer is, you're seeing a lot of AI coming in imaging, and it's already there and it's working. Now, where we see AI requiring more work is particularly in the decision making for procedures like what we are talking about, interventional, things like that. That's where I think we are still waiting. So we are currently having guidelines which are homogenized for the population. But we know that in a given individual, when you apply a guideline, you're always using it as only a support, not, but the therapy may be completely different in a given situation. So how do you bridge the gap from a guideline to a one individual is what the AI needs to be doing, and that's where more work is required. So currently in the US, you're right, so the AI is being used more in genomics, oncology. You already see that it's happening there. There is a gap, big gap in cardiology. It's already happening. It's happening in imaging. We are seeing that happening. I presented some information. For example, you can extract information from simple thing like EKG, and you can use that for understanding what the echo is going to show. So that kind of extrapolation, and that is already there. But with regards to therapies and guideline risk stratifications, I think we're going to see in the next 2 or 3 years, I'm very confident that it's going to change.
Patient is usually in the complex situation, not only have one single situation. So if you decide, when you do decide therapeutic plan, if the therapeutic decision by yourself and by AI is different, what therapeutic plan do you want to use?
Yeah, I think we are never going to use AI as a replacement to your clinical judgment. What you're going to use AI is to summarize the available evidence and see the recommendation for a given scenario. But then ultimately, I think the physicians are going to be using that for making their own judgment. But it's very important because particularly, let's say if there is someone just coming out of the training and he doesn't have the wealth of the knowledge, at least there is some element of recommendation that is available to them to be able to use it. Will it replace the human clinical judgment? I doubt it. At this moment, I think, as I said, that we're going to use it for standardizing our approaches in a given individual patient, but only as a decision support tool. We're not going to replace our ability to apply it in a given patient. And moreover, I think there's a lot of work that requires to be done because it's not so simple. I think I'm summarizing it very easily, but if it has worked in oncology and other fields, other field, why not in cardiology? There is a need for exploring us at some of these opportunities together.
Okay.
So, one question. How do you see the future of echocardiography, especially strain echo?
Oh, yeah.
And strain will replace the ejection fraction, or more sophisticated strain will be appeared or not, or non-invasive imaging.
Yes.
What do you think about
So strain has been there for measuring cardiac function for the last about a decade now.
Yes.
And now we have seen that the societies have come together and they're standardizing the platform, and it's become more robust and more reproducible.
Yes.
But even despite that, I think for a common cardiologist, it is very difficult to use strain in routine clinical practice. So what we need is 2 steps. Number one is we need to automate it. So as soon as the images are acquired, the software should take over and make the analysis. After the analysis is done, it should just simply provide the recommendations. So you're finding that this is the percentage change, and make it more simplified.
Yes.
As simplified as your ability to use an iPhone. When I use it for my 1-year-old child, he uses the iPhone and he knows how to move it. He can. If he can use the technology, then I think what we need to do is to use the technology to make it easier for routine clinical application, because nobody has the time. So strain imaging is probably a very important development in cardiology. But currently, I think there is a gap in clinical application related to the complexity.
Yes.
And this complexity, if there's a way for us to simplify using technology like artificial intelligence, it will allow for more common people and common cardiologists to be able to use it for clinical practice in their decision support tool. And this is something that is actively being looked into right now in echocardiography. And your question about what is the evolution of echocardiography has become very, intense in terms of the number of parameters that are coming out. So you have 3D and you can evaluate so many number of variables, and it is becoming more complex and more challenging for people. How do you diagnose diastolic dysfunction? There are so many parameters, so there's so many classification pathway and this way and
Yes.
that way. It requires to be simplified, and that's where I think we need to use technology. It should be as simple as you open up your iPhone and see what's the weather going to be. There's an 80% chance of a thunderstorm. That's what we need. We need a common physician feeding the data and getting a reliable information about a patient, saying, I think this patient has got an 80% chances of developing heart failure in the 6 months, so that we can then focus on how to take care of that problem. So we need to move away from the diagnostics to be able to take care of the patient. Right now, I think we spend a lot of time just trying to understand what's going on. We spend very little time on trying to take care of our patients. And similarly, when we are taking care of our patients, which therapy to use? How do you know which drug or what target is going to work? So that is the area of precision medicine in which I think the echocardiography is going to play an important role. We already have done some work in which what we do is we do a cloning of the information. So we take the echo of the patient or the CT of the patient and bring it into a computational world.
Yeah.
And there in the computational world, you can treat it the way you want. You'd use all kinds of drugs, interventions, and see which is the best way, which is the best outcome for a given anatomy and a given physiology in a given patient. Once you understand which therapy works the best, then you take it to the patient, because every patient is unique. You cannot take the patient on the table, and it's very interesting that surgeons open up the patient and they're looking at the valve, and then they're making decisions in their mind how they're going to cut it and sew it.
Yes.
All of this has to be done before.
Yeah, right.
Because there is no experimentation on the table, because not everybody is the greatest of the surgeon. You need to be able to develop some of these decisions up front so that you can provide that kind of an aid. And that in that situation, I think echo and imaging is going to allow us to take this information and do some of this work, surgery or therapies, before you actually apply to a patient. And that's where I think the work of sonographers and physicians is going to shift.
Yeah.
We're going to, just like in electrophysiology, shifted from simple ECG to becoming more of doer of things. Same way, I think an imager is going to move away from just simple diagnostics to actually someone who can be architect of the therapy planning. So, so that you can sit in a team-based approach with your physician colleagues, your surgeon colleagues and interventionists and say, hey, you know what, I took this information, I put it into my model, and this is what the therapy looks like. This valve size will fit well. And some of it, by the way, we already do in the intervention structure. So when I sit down with my structural interventional team, they're always looking to me for some opinion about whether mitral clip is going to work or what we need to do, open surgery and so on and so forth.
Okay.
But same thing, we need to quantify it a little bit better and make it more predictable. And that's where I think the imaging is going to probably shift. So we're not going to lose our jobs. We're going to evolve in our abilities to do things better.
I see.
So you mean the nowadays train is enough, or some more?
I think there is a lot of exciting development in ultra fast echocardiography, ultrasound imaging, in which you can do lots of new types of analysis and interpretation. 3D is technologically day by day is becoming better and better. the probes are becoming miniaturized. There is fusion imaging coming in. So I think there is a lot of new ways of doing things that will evolve, and I think we in general are evolving. So when you talk about strain imaging, I think it will be incorporated in some of these applications for enriching the information in a patient.
Dr. Sengupta, how much for the AI you use? How much? Cost.
The cost, no, I think just like, if you talk about technology, in my routine clinical practice, for example, when a patient comes into my, in my office, I use some of these technologies at the point of care, and I don't cost more money to them. So the standard of care should evolve with this technology without costing more money. Just like our cellular phones, in the past, what they cost, and they have now become cheaper, and the technology is becoming better.
Yes.
The same way, our care of the patient, the cost should not increase, but it should become more precise for the given cost, in the same cost, and we should be able to deliver and provide that same amount of care in the same amount of cost without making it more expensive.
Okay.
Okay.
Yeah.
My last question is, your academic achievement is very famous for Korean cardiologists.
Oh, thank you.
So, can you tell us how have you developed your incredible passion for research for young Korean cardiologists?
Yes, I think I attribute it to my mentors. So I was very fortunate to have my mentors when I came to Mayo Clinic, Dr. Kandaria, Dr. Jim Seward, and Dr. Tajik. Yes, and others at Mayo Clinic kind of gave me the initial opportunity to develop the skills that were required for good research. So the most important thing I would again say is a great mentorship. So for young cardiologists, you know, and a mentor does not require to be present in front of you all the time. Even now I have mentors. So you have Dr. Jagat Narula, you have mentors. You know, I work in the as an associate editor for Jack Imaging, and when I go into the conference call and all my colleagues with whom I talk, everybody provides you like education. They all have mentors all the time with you. So mentorship is basically something that you it's an association after a period of time in which you live and you get inspired by. And I think this is the most important aspect of medicine. The most important inspiration for me is how do I do something new and different for a patient? And my questions, if you would see, even if I look like I'm a technology-oriented person, have always come from the bedside. Why is why do you feel the apical impulse? Why does it move up during a cardiac cycle? What is the motion? If ECG we know, why does the tissue Doppler have all the squiggles in the wave from where it is originating? So I think keeping an eye in your clinical practice and trying to address something that you see and you don't have an answer for, that's the most important aspect. And after you see that unknown aspect, then taking to the mentors and finding the right sets of individual. And I also want to say that collaboration. In my lab, I am very fortunate that I have groups of engineers, I have research fellows and students, and we create an environment where you're seeing at a problem in a different way. And that's very critical. When I see something in my hospital, in my imaging, in a patient, I bring it down to my center, in the research center. And an engineer who's not a doctor looks at the same problem. He has a completely different set of looking at it.
Yes, right.
And he teaches you a perspective that you would otherwise not have. So this ability to involve people so that you can evolve your thinking is what leads to better research and research approaches to answer some questions. Okay. So these are the ways that have always, but again, obviously, being intensely inquisitive, be always interested to understanding and questioning your clinical observation is what makes me go around. And when you have an ability to answer that, I think it brings an element of satisfaction that is more beyond than the transactional aspect of a medicine, not as a business. It's more like related to something creative and something like an artist does. So it brings in a element of satisfaction, and that enthusiasm and that satisfaction is what makes you go on throughout your career and helps you develop yourself, and that's very important for me.
Thank you. Thank you. So, any question, Dr. Abhay?
Thank you very much.
Thank you
Thank you.
very much for having me here. I really appreciate the invitation.
Yeah, we'd like wrap up this interview. Thank you joining us, and thank you for your inspiring lectures.
No, absolutely.
Thank you.
Very much. Thank you.
Thank you.
Thanks so much.
Yeah.
Thank you.
Thank you.
Thank you.